Thank you, Mike. It's lovely to be here. It's so nice to see so many people in person, and many of whom I haven't met in person before. But seems I feel that I know you from 2 years of Zoom calls. And I'd like to thank Mike and Vanita and the team as well for the absolute passion and enthusiasm that they've brought to this, and the sheer drive and the clinical leadership, which is absolutely essential to to developing and promoting these, and thanks, at the moment we've got quite a number of people in the lecture theatre and a number of people online as well, so I think the IT teams have really worked well to pull this off. So for those of you that don't know me, I'm Julia Reynolds, and I have the pleasure of leading the CVD and respiratory team at the Innovation Agency. And we're working right across the region to help improve the outcomes for people with lipids, and to work with the NHS and others to make this happen. So I'd like to just really kind of bring this down to a human level and actually have us all thinking about what this means to us as people, because we're all people in this region. And over time, all of us will have these risk factors in our lives as well. Certainly, you can see from this slide that there's the staggering amount of people who are dying from CVD events. Thinking of it in terms of something like 1 death every 3 minutes, 100,000 hospital admissions from heart attacks, and that's 1 admission every 5 minutes. And actually the strokes as well, the admissions for strokes, and there's a cost. There's also there's the financial cost, of course. We're all aware of those resources, but there's also the human cost to this as well. And we probably all know people in our families and our peer groups who've had cardiovascular events. And how many times have we thought, if something had happened differently with cholesterol, something had happened differently earlier with blood pressure, and you don't say anything sometimes because you think, well, it's happened now. But actually, I think we all need to be very aware of the role that we're all playing in this. And we're all playing a very crucial role. And actually, we're the ones that know about this. There's a lot of people out in our communities who really don't understand what cholesterol is. And we do sometimes really need to take the time for people to understand it. And I think as well, we've heard about the medications that people are taking that sometimes find it difficult to take statins, or feel, that they've heard bad things about statins, and actually perhaps think, know more about blood pressure and the importance of blood pressure, but less about their cholesterol. And I know that the cardiac rehab team here have spent, a lot of time and energy supporting their patients that they're seeing. So we're talking about large numbers of people here, and actually we can't do that in a non-cohesive way. We have to think about population health approaches in our regions. There's too many people who are suffering or potentially could be suffering because they have raised cholesterol, and actually we need to think about doing things at scale. And of course, when I talk about doing things at scale, people will automatically think, well, I'm really time pressured. I've got so much to do. I've got the vaccine program. I've got, big backlogs of people and waiting lists. And I think that we do have to think about how we achieve what we need to achieve for our population, working with partners, working cleverly, working smartly, and of course, thinking about digital opportunities that are open to us, because we do need to think about innovation. And certainly we'll be hearing a lot more about some of the innovations that we have around lipids as well here. But I mean, for our part, we want to try to help roll out, improve, amplify and support our regions with all the work that they need to do for their populations. But one of the important opportunities in coming together like this is that we get the opportunities to hear about what other people are doing, and to think about how we can change, move forward, improve, share our own good practice with others, and be able to try to provide a little bit, some energy, some passion to bring to our colleagues as well about the importance of the work in this area. I don't need to really talked too much about this here to this audience, because we all know about the national ambitions. Certainly the Academic Health Science Network, who have lipids as part of their programme over this year, and probably we've got it for this year, and we certainly think we probably will have it for next year, 23-24 as well. We're driven to help support the 10-year cardiovascular disease ambitions for England, which of course we also have in the national plan. Now, I wanted to show this slide, and I realise that it's difficult to actually read some of the small print, so I just want you to look at it in its entirety, and I want you to look at the map of England and look at the darker orange colours. The darker means the more severe and poor outcomes for people around cardiovascular disease, and I think it's very, very clear from the diagram that we have a huge challenge in the north. And when you look at the scarf diagram on the right, which I love these scarf diagrams, I think they really depict nicely a picture. We can see just by looking at that that we've got the southeast who have a much lower challenge to the northeastern Yorkshire, the northwestern Midlands. And actually, when we're talking about the figures that I mentioned earlier about events that are happening every 5 minutes, we can actually think that that's going to be worse for us because we've got poorer health outcomes. So this scarf diagram is actually the layered risk factors in our area. And for those of you who can't see the small bits, it's things like smoking and number of admissions to hospital for cardiovascular event. And I just want you to think a little bit about that. Is really not fair, is it, that we should suffer more? And we need to think of it in our own terms, because we're members of these communities. This could be us. Who knows what their cholesterol is, and do we do this for ourselves? Do we think about this ourselves, for our own selves, as for our patients and our colleagues, our friends and our family? This divide, this north-south divide, has been evident for a number of years, and I'm sure there's a whole host of reasons as to why we have poorer health outcomes in our area, and we can't tackle all of them. But we do need to understand that this is hugely important, and it is making a massive difference to our long lives in our region, and actually it's the human cost as well. So people who have cardiovascular events, many of them are preventable. So I do think that there is an importance for us to think about not only our work but also ourselves in this. And how we can move forward with thinking about that. I just put this diagram on as well because these are the Liverpool PCNs, and again, it's very small and you won't be able to see, but I just really want you to see the depiction of the scarf diagram. And again, these are the same risk factors that we had at a national level. Now, I will say that at the bottom, Croxteth and Norris, I don't think they've got their full data set, so I don't think that they're hugely, ahead of everyone else. I think they just haven't managed to get the data on that one. But it just gives an idea that even in a PCN, there is variation as well. So just a quick word about the AHSN network, the Academic Health Science Network. So we have a network of networks, and we have a real focus on driving systems engagement, development and implementation of improvements. So what that translates into real life is that we all 15 AHSNs across the country are focusing on lipids, and the map on the side shows the other AHSNs across our country. We work with the NHS, and we also work and partner with industry. And I'd like to just go back to what I said before about being able to make this very challenging task around lipids. How can we make it work? And we do need desperately to make our partnerships work as well as they can, to get the outcomes that we need for our patients and our population health. So if we're all working together, we can show what we can achieve. And certainly you'll hear today about what we've achieved over a very difficult period, over a pandemic, and the hard work that's gone into doing that, but actually the satisfaction in the improvements that have been brought to bear from that work. So all the academic all the academic health science networks are working together to develop our partnerships to help embed the pathways, the lipids pathway that I'm sure you're familiar with, the statins intolerance pathway as well, and to work with the huge amounts of different professions that we have in primary and secondary care. So we do come together as a network as well to share our good practice and our learning from our area. So each area is different, and each area has a different profile of staff and organisations and different ways of working, but there is certainly a lot that we can learn from each other. This slide's just looking at what drives our metrics, for how are we measured as an academic health science network around lipids, and actually it's mainly around the products that are being prescribed for people. So to actually look at those people who are taking medications but are maybe not optimized, and actually making sure that there is the right profile of prescribing going on around these patient groups. And also our engagement is measured, and we have a target around familial hypercholesterolemias too. So this is just a little bit about, we talk about all these different things we do about context and awareness raising and building will and supporting implementation. But actually, what does that mean in practical terms? What sort of help could you expect from the innovation agency? So certainly we do a lot of contextual work, working with ICSs, identifying the priorities and the needs in the ICS, and working with regional leads to talk about how we can make inroads into helping that happen. We're doing a bit of work at the moment with the new Cheshire Merseyside familial hypercholesterolemia serve the ground and up and running, and that will be really a useful another structure to help support those patients with genetic high lipids. We're doing a lot of awareness raising, so we have a Heart Heroes team. They used to be the AF ambassadors because we did a lot of work around AF, but they're now pivoted because we're doing work around blood pressure and lipids, and they're Heart Heroes. They go out from time to time, raising awareness, providing patients with information about cholesterol. They've got a nice little kind of model of cholesterol just to show people what it looks like, what the heart looks like and the valves look like and the buildup of cholesterol looks like. And we do a lot of work with social media. We've got a lot of access to education, so we can work with different areas to understand what their needs are around education and how we can support that. We try to do work again, around the hearts and minds, because we do know that there are so many competing priorities at the moment that often lipids isn't one of them. And we do try to sort of raise the awareness and try to have conversations with people at clinical director level and in the different trusts about the importance of this work and how, working together, we can sort of find good ways to look at making that happen. And actually using our data effectively is one of the key elements of that. Actually on the ground, with regards to supporting implementation, we can actually work very specifically with teams to help try and get things off the ground, and that might be around providing information, like supporting searches and giving other ongoing support if required.